Okay. Well, good morning, everybody. Thank you for joining us early. We're happy that you're here with us. My name is Stavros Drakos. I'm one of the cardiologists at the University of Utah. And my co-chair had to leave a little bit early, Dr. Sineha. So I would like to ask our panelists to introduce themselves.
Ismael Sala, CV Surgery on the University of Houston, Texas.
Not sure if this is working. David Barron, Cleveland Clinic, Florida, section head, heart failure.
Jim Burke, Interventional Cardiology, Medical Director of Acute MCS at Lehigh Valley Health Network, Jefferson.
Ricky Hansrud, Critical Care Cardiology at Vanderbilt University Medical Center.
Laura Wieste, Nurse Practitioner at Memorial Hermann, Memorial City.
Jay Swishenberger, Critical Care, CT Surgery, University of Kentucky.
Thank you. Well, we have a full program, and I would like to ask our first speaker, Jonathan Emling, who is a program coordinator for ECMO and cardiogenic shock and TEM MCS at the St. Thomas Heart at Ascension St. West Hospital in Nashville, Tennessee, to come and talk to us about why should every program have a shock coordinator.
Thank you. So I have no relevant disclosures to this talk. So I want to start off with two quotes, probably things that lots of people have heard before. If you can't measure it, you can't improve it, and if you can't measure it, you can't manage it. So a lot of what I do as a shock coordinator is measuring our outcomes and looking at kind of the raw data and putting it in a format that is meaningful for our shock team so that we can do things with it. Because a program director, a really inspired champion, can only do so much without a team supporting them who really gathers that data and looks at what our outcomes are and what we're doing with them. So the program coordinator needs to be somebody who wears a number of hats. They're a clinician, they're an administrator, and they're a researcher, kind of all in one. It's hard to build a program without a good coordinator, and the concept of coordinator, the nurse coordinator, is common in a lot of other time-sensitive conditions. So you look at the AHA's Mission Lifeline STEMI heart attack accreditation overview. They talk about needing a nurse STEMI coordinator, not necessarily a nurse, but a STEMI coordinator and a physician champion in both STEMI receiving centers and STEMI referring hospitals. In stroke, the coordinator is also a commonality among higher level stroke centers. The AHA recommends stroke coordinators as part of a growing stroke program. Even in sepsis, we see the word coordinator come up in the CDC's hospital sepsis program core elements. They mention sepsis coordinators, and we have those at our main hospitals and outlying facilities as well. With the advent of trauma centers, as far back as 1986, trauma center designation has paved the way for the trauma nurse coordinator role, and we see mentions of that in the literature as far back as the 80s. The demand for care coordination is being realized in the shock and by default the MCS community. We're all familiar probably with the INOVA team and their talk of standardized team-based care for cardiogenic shock, this sort of lighthouse article that came out a number of years ago. Also, the Extracorporeal Life Support Organization talks about coordinators in their program structure guidelines. And then just last year, the folks at MUSC published a really insightful article talking about the temporary mechanical circulatory support coordinator. So we see these coordinator roles really popping up, and the question that kind of comes to my mind is, are we over-coordinated sometimes? And I don't think there's such a thing. I think we really are realizing what coordinators do for a program. So what are the commonalities between all these things where we see coordinators in stroke, sepsis, and shock? Well, these are time-sensitive conditions They require cross-department collaboration in the hospital between multidisciplinary teams. There's often, although in shock we'd like some more, I think, there's often evidence-based care bundles that go along with these conditions, as well as goal-directed therapy, quality markers that may be established either by outside agencies or your own internal quality markers that you'd like to keep up. And then finally, Center of Excellence designations, whether that's ELSO Center of Excellence, chest pain centers, stroke centers, all these different organizations that have different center designations often come with coordinators to maintain those designations and make sure you're meeting your metrics. So what does the shock coordinator do day to day? I do a lot of data collection, so I do chart abstraction and review. I build databases, dashboards, lots of different reports to different committees throughout the hospital, and we participate in registries. Right now, one of the more exciting registries out there is the AHA Cardiogenic Shock Registry. There's also things like individual hospital registries, the Cardiogenic Shock Working Group, and then you can build your own registry. Everybody's probably familiar with REDCap and all the things you can do with that, and we utilize that quite a bit too. We like to build our own quality metrics, talk about protocol development, order sets. Y'all can read, so I won't read the whole slides, but outreach, RCAs, and case reviews all fall under the purview of shock coordinator. This article published last year talks about 12 quality shock programs in the US, and the key, the through line through all of them was a cardiogenic shock coordinator. So I think that's interesting that we're finally seeing in the literature some of this borne out about shock coordinators and their role in high-performing shock programs. I like to think of shock coordinators and just coordinators in general as force multipliers. They are the sort of special ops of the hospital who can weave in and out of different departments and really make a big difference, a bigger difference than just a single person in a single department. For shock, this is cross-department collaboration between the cath lab, the ICU, the ED, and the floors. I handle funding requests. One of the big things that I think is overlooked sometimes is collateral, things like badge buddies, pocket cards, and posters, things that remind people, hey, I got to think about this rare condition of cardiogenic shock, and I got to know exactly what I'm looking for and what to do when that comes about. Finally, the shock coordinator has sort of a 20,000-foot view of the program. As great as a dedicated medical director is, they don't see every single shock case. You might be on for a week at a time or a few days at a time. The coordinator should really be seeing every shock case. They should be able to pick out these commonalities, whether we're doing things well, things we're not doing well, and bring that to the attention of the medical director and the shock team, whatever structure you have in place as far as case reviews or RCAs. So who should be your coordinator? Ideally, we have this dedicated FTE, but some of you are probably thinking about your administrators and know that you're not going to get a dedicated FTE. So who can we schlep this onto? Maybe we can schlep it onto the ECMO coordinator, and that's what happened to me was we saw that we couldn't look at ECMO cases without looking at shock cases and where they came from. Maybe STEMI or chest pain coordinators. I do a lot with our STEMI and chest pain coordinators. Rapid response, ICU CNSs may be a good person for this role, or the VAD coordinator. So I won't read all these, but these are the key responsibilities if I was to build my job description out, what I would do. A lot of education, a lot of quality improvement, coordinating the one-call shock activation, and then writing protocols for MCS initiation, maintenance, weaning, and transfer. I think things that would make my job easier and that we need in the shock world and for us to further shock coordinators is accreditation for shock programs, regionalized systems of care. We need class 1 recommendations for shock to build those quality metrics and goal-directed therapies, and then incentives for registry participation. So in conclusion, shock coordinators have historically been key to effective programs with time-sensitive critical medical conditions. They touch many departments. They include other coordinators in collaboration with them, and the best candidates may come from multiple backgrounds when it comes to who should be your shock coordinator.
Excellent. Thank you. Please, can you stay? We have a few minutes for questions. This is open to the audience and to the panelists. Please.
Jonathan, I'm going to challenge you. I looked at your list of all the things that you do, and what I'm going to say as a physician, the most important is that you're the neural network of what's not only available, but what's accessible. Any idiot can buy equipment. Any idiot can build a hospital. But only you're the one that knows how to address these time-sensitive injuries that are looming in the patient. Stroke, MI, looming sepsis. All of those, for the last 3 days, we've heard how time-sensitive intervention is and how choosing the right therapy is important. But you can choose the right therapy until you're purple, and if the coordinator doesn't have accessibility to the talent and the equipment and the room, you can't use it. So I think you should really emphasize the fact that you're the neural network for all of this. I don't know, I know who to call, but if they're not available, what am I gonna do? Start screaming? Yes, I always do, but I'm gonna call you.
That happens a lot.
Good.
Somebody doesn't pick up the phone, the next call goes to me, and I just use a little add call button on my iPhone and bring them into the call.
I'm sorry. These days, funding an FTE is incredibly difficult. Do you have some way of showing ROI on the position to your institution?
No, but we need that. We need to be able to show before and afters, and that would be a great project for somebody to show, does this reduce length of stay possibly? Does this reduce device utilization, or at least picking the right device for the right patient?
I don't think any of us agree we need shock coordinators. It's just the fight we have to do with the administrators.
Exactly, and there's 2 of us at our institution, so it's not just me handling all shock, ECMO, and temporary MCS. It'd be too much for one single person.
Quick question, Jonathan. Great presentation. What advice would you give to a program that is thinking about creating a shock program in terms of who to actually employ for this? I would imagine if I approached you and I'm making a new shock team and I need a number of different investors and stakeholders, what advice would you give to that program for the coordinator role? An experienced nurse, fresh talent out of nursing school, somewhere in the middle?
I think an experienced nurse is necessary. I am an ICU background myself, but in my role, I really had to sit in the cath lab and learn the cath lab workflow and the OR workflow even to understand where can we intervene and where can we kind of put these little light bulb moments for the nurses and nursing staff and to notify the operators, hey, we got shock, this is our protocol, we need to start following the pathway. So you need somebody who I think is experienced in nursing from a critical care perspective just to understand the hemodynamics, but also can weave in and out of different departments and really just make friends throughout the hospital, because the biggest thing for me has been making friends in other departments and making those natural connections.
I have a
Can you
question.
give us a-
Sorry, Dr. Sullivan. Do you have any kind of organized nursing education where you're educating the nurses what to look for shock?
We do. We have integrated CPO and PAPI into our charting, and we have like a presentation that they get as part of their CVICU orientation that just talks about shock identification, why CPO and PAPI is important when we're looking at our patients beyond just cardiac index, and kind of how that fits into our overall pathway. We just basically blatantly plagiarize the INOVA people as far as their shock pocket cards, and as far as escalation, when they should call once we've put on vasopressors or escalated.
You really want to show your value, measure time to treatment from when you get the call. Because every one of these talks for the last 3 days has shown time to treatment is critical.
Mm-hmm.
Can you give us a brief description, like a shock activation? Give you an example. Somebody in the ER is waiting to be, have some chest pain, is waiting there, witness arrest, VFib arrest. Mm-hmm. What happened? Who received the call? How you?
So first call from the ER and a VFib arrest would be the interventional cardiologist. The interventional cardiologist then calls heart failure, who brings in our critical care anesthesiology, and they would all meet in the ER to discuss this person. Likely they'd be in the cath lab by the time that this discussion is already taking place, and they'd have just kind of a meeting of the minds in the cath lab in real time. And if it's on off hours, it'd be over the phone.
Excellent. Well, we need to sum it up, but David, if it's very quick, please.
Quick question. So with 2 of you, how do you manage the 24/7 role? When I was in one of my previous institutions, my coordinator pretty much always answered the phone like I do, but that's not really feasible for long-term survival.
Well, when there was one of me, it was 24/7. Now that there's two of us, it's 7 on, 7 off. And we actually have brought in one of our new chest pain coordinators to take some of the call for this as well. So we're dividing it up into 3 people now. I'm much happier. I'm planning on staying.
So we need
How
to wrap
long's
it
it
up.
been since you've heard that old school schedule, huh?
Jonathan, there are a lot of people that they're texting us that they want your slides, so don't leave. Stay here because they will ask for, give you your emails so you can send them. I see a lot of people around wanting your slides.
Sounds good. Thank you so much.
So I'll be the second.